Hi, everyone, and welcome to Fit for Fellowship, a survival guide for the first-year general cardiology fellow. I'm Megan Pelter.
And I'm Stacy Sy.
And welcome back. So we're going to dive straight into our next lecture, which is by Dr. Lindsay Short of University of California, Riverside, and she'll be giving us an excellent talk on ventricular arrhythmias. So a little bit about Dr. Short. Dr. Short received her medical degree from the University of Southern California, Keck School of Medicine, and completed internal medicine residency, again, at University of Southern California / Los Angeles County Medical Center. She then went on to complete a fellowship in cardiovascular disease from the University of California, Riverside, before completing that just this past June. So we're all very proud of her and very happy to hear her talk. So let's move straight on to it.
Hi, everyone. My name is Lindsay Short. I'm a recent UCR fellowship graduate. As someone who's just on the other side of fellowship, to all of you who are at the beginning of this next phase of training, I want to say congratulations, and I wish you an amazing 3 years ahead. The start of fellowship is really a whirlwind. Maybe you just finished residency, you moved again. Now you're trying to learn all the new skills of a cardiologist, but instead of going home to study echo views or catheters, you've been busy reviewing parathyroid pathophysiology and prepping for your board exam. I remember the chaos, but hang in there, read a little bit each day, learn everything you can from the patients you meet and the attendings you work with, and enjoy it because you're already making a huge impact in your patients' lives. To get started, we're going to discuss ventricular arrhythmias today. I think it's one of the more important topics to discuss because these arrhythmias are often life-threatening and they require rapid identification and action. But for that reason, they can be a little intimidating at the start of fellowship, but hopefully this will be a helpful reminder. Just as an outline of what we're going to cover today, we're going to start with an overview of ventricular rhythms. We'll focus in on ventricular tachycardia, then accelerated idioventricular rhythm, Torsades de Pointes, and ventricular flutter or fibrillation, and then we'll do some practice cases. So ventricular rhythms, they obviously arise in the ventricular tissue. This can be from the Purkinje fibers, the bundle branches, the myocardium itself. It could even come from the valve cusps, the annuli, and also the aorta or the pulmonary artery. And this image here just shows you some of the different areas where they can arise from, which we already mentioned. Unlike supraventricular rhythms, which in accordance with their name arise above the ventricles and eventually reach the AV node and subsequently move through the specialized conduction system, resulting in a narrow QRS complex, ventricular rhythms arise within the ventricular tissue, most often outside of the conduction system, and therefore they depolarize slower as they move from cell to cell, and that leads to a wide QRS complex. Definitely they can look different based off of where the rhythm is coming from, but this is just a generalization. In terms of symptoms, they can be really variable depending on the patient and often the underlying pathophysiology that person might also have. In general, most people will feel palpitations, they could have shortness of breath, they might be lightheaded, and they can have atypical chest pain. Those are pretty common. If you have someone who has resultant hemodynamic compromise because of the ventricular arrhythmia, they might also be experiencing weakness or fatigue, altered mental status, syncope, or they could even present with sudden cardiac death. If I put a little asterisk here at the bottom, the presence of other cardiovascular conditions influences symptom severity. Whereas being in VT might make someone have atypical chest pain, you can imagine that if someone has, for instance, significant underlying coronary artery disease, they may not feel atypical chest pain. They might actually experience significant angina from decreased coronary perfusion. Some patients might come in and they'll be talking to you and you'll be surprised to see that they're in ventricular tachycardia or another rhythm, and other patients might be extremely symptomatic. So it just depends on the person. The causes of arrhythmias are variable, but in general, they fall into three categories. That's abnormal automaticity, triggered activity, or reentry. Although automaticity is an intrinsic property of all myocardial cells, there is a natural hierarchy of pacemaker function, with the SA node discharge rate exceeding all the other pacemakers in the heart. Abnormal automaticity occurs when tissue that does not normally serve as a pacemaker generates an action potential. Cells of the His-Purkinje system can discharge at a slow rate, but they're normally overdrive suppressed from the SA node or the AV node. But automaticity can be induced by certain pathologic conditions such as ischemia. Triggered activity, on the other hand, occurs when there's an oscillation in membrane potential, and if the oscillation reaches threshold potential, then this can occur. If the activity occurs before repolarization has completed, it's called an early after depolarization. If it occurs after depolarization, it's called a delayed after repolarization, which is what's seen here, or a DAD. DADs are thought to be due to intracellular calcium overload. Some of the early after depolarizations are believed to be responsible for arrhythmias associated with acquired and congenital long QT syndromes, where slow heart rates and long coupled intervals can promote the development of early after depolarization. And faster heart rates and shorter coupled intervals can suppress them. And that'll make sense when we discuss the treatment of torsades. With reentry, you end up with an abnormal circuit within the ventricle that's triggered. And this is most commonly seen with SCAR and VT. So these are just some examples for abnormal automaticity. Often this is caused in ischemia after reperfusion and occasionally with electrolyte abnormalities. Triggered activity I mentioned, that's often the cause of long QT leading to VT, but also beta agonists, exercise, and some drugs can cause triggered activity. In reentry, I already mentioned that if you have SCAR after an MI, you can have SCAR-mediated reentry. Also, ARVD and congenital heart disease, both of those conditions can sometimes have reentry circuits that can be triggered and lead to things like VT. So these, I already kind of mentioned the different mechanisms by which you can get VT. This is just to focus in on some of the common drugs that can lead to ventricular arrhythmias, antiarrhythmics themselves, QT prolonging drugs, bronchodilators, H1 blocking antihistamines, macrolide antibiotics, psychotropic agents, stimulants like cocaine and methamphetamine, alcohol, caffeine, and tobacco all are commonly implicated. So if you see a patient, make sure you ask about these things. Moving on to ventricular tachycardia. So now we're just going to discuss some of the common arrhythmias. We'll start with VT. It's one of the most important. So identification obviously occurs often through the ECG. Just in general, this is an arrhythmia that's produced by an irritable focus. The rate is usually greater than 100, as would be implied by the name ventricular tachycardia, but there are some cases where you have slow VT, and the rate can vary from 70 to 250 beats per minute, depending on the type. The QRS complexes are abnormally shaped, and they're greater than 120 milliseconds in duration. The ST to T vector will point opposite the direction of the major QRS deflection. In general, if you have someone that has 3 or more ventricular premature complexes, this is actually that meets the definition for ventricular tachycardia. But in order for it to be called sustained ventricular tachycardia, you have to have this arrhythmia present for 30 or more seconds, or also if it's shorter than that, but the patient has to have the rhythm terminated because they're experiencing hemodynamic collapse, that also counts as sustained ventricular tachycardia. The QRS complexes can be uniform, in which case you refer to it as monomorphic, or they can be variable, which you'll hear the terms multiform, pleomorphic, or polymorphic. Clinical features of ventricular tachycardia. So we already kind of mentioned that just a little bit when we were talking about ventricular arrhythmias in general, but the symptoms depend on the rate. The patient might be conscious, but they could be hypotensive. They could be unconscious, or they could be sitting in front of you looking okay. In general, look for a history of an MI. Look for those who have known cardiomyopathy, congenital heart disease, or valvular disease, because this will provide the substrate to cause ventricular tachycardia, and it's a little more common. On exam, you might notice intermittent Canon A waves, variable intensity of the first heart sound, or variable peak systolic blood pressure. And the last three, these things are all due to AV dissociation, which we'll talk about in just a little while. So one of the biggest things that comes up is the need to differentiate ventricular tachycardia versus SVT with an aberrancy. And this is often hard. People always kind of forget what some of the criteria are. But in general, if you understand how these criteria come about, they're a little easier to remember. So we'll go through these things because obviously it's important to, there's implications for the treatment based off of what the actual diagnosis is. So the very first one that I'm going to mention is, we'll look at this first box. So the Brugada criteria are these are just one set of criteria that you can use to differentiate the two entities, but I like how this little graph kind of laid it out. So the first step, look for positive or negative concordance in the chest leads. So normal activation of the ventricles occurs from the apex towards the base. It also occurs from the endocardium outwards to the epicardium, and that it occurs in the septum from the left towards the right side. And this generally leads to a progression of predominantly negative to predominantly positive QRS complexes across the precordial leads. So that's what you would normally see in an ECG if the person isn't in ventricular tachycardia. But if you see this is an example of positive concordance. And here you can see that all the QRS complexes are upright from V1 to V6. And what this implies is that there is VT and it's occurring somewhere near the base of the heart and moving down towards the apex. Alternatively, you can have negative concordance. So you can see here from V1 through V6, all of the QRS complexes are downgoing. This is the T wave here. So this is the QRS that's downgoing, and it persists that way throughout the entire precordium. So if you see this, you know that the normal activation sequence isn't occurring. Okay, moving on to the second criteria here, you look to see if any RS complex in V1 to V6 is present, and if so, you look to see if the RS is greater than 100 milliseconds in one of the precordial leads. In VT, the initial activation, it doesn't occur in the specialized conduction system. Instead, it starts in the ventricular myocardium and it moves from cell to cell. So the initial activation occurs slowly, and that'll give you an RS that's greater than 100 milliseconds. So keep an eye out for that. The next thing is to look for signs of AV dissociation. So AV dissociation This isn't something that's unique to ventricular tachycardia, but it's important to identify it if it's present because it will definitely give you a hint that what you're dealing with is ventricular tachycardia. Um, so AV dissociation, this is, since the sinus is still pacing the atria, you have P waves that are present, but they're hidden behind QRS complexes in most cases. Sometimes they peek through, which is how we can determine that it's present. But the independent pacing of atria and ventricles is called AV dissociation. Okay, and capture beats and fusion beats are two findings that'll tell you if there's been independent pacing of the atria and ventricles. So it's kind of two different ways that you might see AV dissociation expressed. So this is showing a capture beat. So you can see here, it looks like there's something that is concerning for VT going along. And then all of a sudden you see a P wave and you see a normal narrow looking QRS complex. So this is a capture beat. So a sinus paced beat here, it finds the ventricular system receptive to depolarization. And so all of a sudden you have a normal appearing QRS complex amidst this wide complex. So these P waves are also present throughout here somewhere. It's just harder to see them because they're buried behind the QRSs. But when one is comes through and it's timed perfectly, it can capture the ventricles, and then you suddenly get this one narrow beat. So that's a capture beat. A fusion beat is when a sinus paced beat finds the AV node and part of the ventricles to be receptive to depolarization, but the wave of depolarization subsequently meets ventricular depolarization, progressing from the focus in the ventricle. So what you end up with is a beat that looks like it's sort of halfway between the ventricular rhythm and the native QRS that's coming from an atrial paced beat. So here, the atria started to depolarize and send the signal down the AV node and into the ventricles, but there was still a wave of depolarization from the ventricles that was occurring. So you end up with this fusion beat. So again, that's a sign that you have AV dissociation. And both of those things, when present, will point you towards ventricular tachycardia, as opposed to SVT with aberrancy, where that can't happen. Okay. The next thing to do is to look for some signs of or some characteristic features of VT. Often you can see them in the septal leads and in V6. And so here what you want to do is identify if you have you have a right bundle branch morphology or a left bundle branch morphology. So let's look a little bit at one of these patterns that's indicative of VT. So if you have right bundle morphology, there should never be a Q wave in V1. V1 is a right-sided lead. And if you have right bundle branch block, the polarization would move from the left to the right across the septum. So you wouldn't ever see a wave that's moving away initially. This would not, this shows that there's activation coming from the wrong direction. So here what we're seeing is we're looking in V1 and there's a Q wave implying that the depolarization is moving in the other direction or away from your right-sided lead. So it's moving towards the left, which isn't what we would expect. If you look in V6, which is a left-sided lead, you're seeing basically a mirror. So here, you're seeing a little R wave at the start. So you also wouldn't expect to see that if you truly had a right bundle branch block. So if you have this sort of right bundle morphology where you have a predominant R wave, you don't expect to see, again, a Q wave in V1 or this little R wave in V6. By the same token, in left bundle morphology, the septum should be activated from right to left if there's truly a left bundle branch block. So your left-sided leads like V6 should not have a Q wave. So the presence of it would be concerning for VT. Okay, so that was just sort of one of the classic criteria. There are a few others that you can look for that's described here. So in general, if you have right bundle morphology, but you have a taller left rabbit ear, that's concerning for VT. So there's a few different signs that you can see. And this isn't all inclusive, but these are some great patterns that sort of give you an idea that you have VT as opposed to SVT with aberrancy. But just remember the history is important. So if you have a patient that has a history of MI and the QRS doesn't show an obvious typical right bundle or left bundle pattern, you should really be suspicious for ventricular tachycardia until proven otherwise. Here's just an example of an ECG that's showing ventricular tachycardia. And it's a good chance to bring up one other criteria which we didn't mention, which is that you can look in AVR, and if you have right superior axis, meaning the QRS is positive in AVR, that's pretty much a slam dunk for ventricular tachycardia, because there really isn't any other condition where you should be having the axis showing right superior axis. So that's also a sign for ventricular tachycardia, and it's displayed in this ECG. There's also AV dissociation, and these little dots are kind of helping to identify it. So if we go through, say we choose lead V2, they've kind of marked it out for us. You can see here that there's a little hidden P wave, but it's not in the same location each time. Here again, going backwards, they've marked it out for us. You can see there's this little blip here in the T wave that we don't see in the other T waves. So always look at the QRS complex, look at the T waves, and look and see if there's anything that could appear to be a hidden P wave. So here we see them marching along. There's a sinus rhythm at its own rate here, and we can see it peeking through at different intervals. Here we can see it's present before the QRS. And then these little white dots are just showing places where you really can't see it because it's just sort of hidden in the QRS complex. But these can sometimes be tricky to find, but look out, compare your QRS complexes, your T waves, and see if you find any little abnormal blip that you can march through. This is also just showing a very wide QRS complex, which can be more concerning for VT. So when it comes to management, we're gonna mostly go through the acute management, since this is sort of meant to be a talk about how to manage patients early on, those first call days of fellowship. I'm not gonna go into the chronic management and talk more about ICDs. I'm gonna focus more on acutely managing the patient while you're alone and you don't have any help. So the first thing to do is to determine if your patient is hemodynamically stable or if they're hemodynamically unstable. If they are stable, you have time to give them medications, and we'll go through some of the medications that are commonly given. But there are other options too. You can consider direct current cardioversion. You can perform ventricular pacing. And as is present in both options, you should always be trying to address what the underlying cause is. If there's something like ischemia that can be addressed, or an electrolyte abnormality. If your patient is hemodynamically unstable, your first go-to should be defibrillation if they don't have a pulse. And if they do have a pulse, then you should be focusing on direct current cardioversion. Though you can also do ventricular pacing, medications, and again, you should be addressing the underlying causes. So for your patients that are hemodynamically stable, you have the chance to give them medications. You can also do this later on with patients who are hemodynamically unstable, but you need to do something else first in those cases. So the first thing would be to give them amiodarone as an option. Your other options are lidocaine or procainamide. For amiodarone, you want to give a load, which is a total of 150 milligrams but you're going to give it over 10 minutes. So it's 15 milligrams per minute over the course of 10 minutes. Then if you want to continue an infusion, the dose is 1 milligram per minute for 6 hours, and then you decrease it to 0.5 milligrams per minute. Lidocaine is another option. The initial load here is 1 to 1.5 milligrams per kilogram. So this one is based off of weight, and you give that as an IV push. And then you follow that up with an infusion of 20 to 50 micrograms per kilogram per minute. The last option is procainamide. This is a load of 100 milligrams IV. It's not weight-based. And you give this over the course of 2 minutes. And then the subsequent infusion is 1 to 4 milligrams per minute. In patients that are hemodynamically unstable, if they have a pulse, you can do direct current cardioversion. And here you should be delivering a synchronized shock at 10 to 50 joules. This is a picture here of an AED. And this isn't someone that is getting shocked because they're in VT. This is someone who has AFib. But I just want to show this screen here. I recommend that you go to the hospital and that you familiarize yourself with the external defibrillator that you have. You want to be familiar with the buttons so you know exactly how to make sure that you're choosing synchronized cardioversion if you want it, and defibrillation if that's what you want. As shown here, you'll often have these little small S's over the QRS complexes. And that's to indicate that it recognizes the QRS complexes and it's going to be able to provide you a synchronized shock. So, make sure that you find this right away. I think oftentimes when you're a resident, you might practice running a code, or you might have different roles, but you're maybe not always the person that's pushing these buttons and making the selection. So make sure, you never know what situation you're going to be in. Make sure you know how to use the buttons, how to charge it on your individual machine, and that you feel comfortable doing that. It'll make you feel more comfortable in your early calls should you need to cardiovert a patient. Other options for patients that are hemodynamically unstable include overdrive pacing. This is an attempt to compete with the arrhythmia and outpace it. If you do choose to do this, just be prepared to defibrillate, because in rare cases, trying to overdrive pace can lead to ventricular flutter, or it could deteriorate to VFib. So you might need to be ready to defibrillate and start ACLS if needed. Okay, the next rhythm is accelerated idioventricular rhythm. This is when a ventricular focus takes control of the electrical conduction system by generating an impulse that's faster than the sinus node, and it's usually at a rate of 50 to some say 100, some say 110 beats per minute. It's most commonly seen in acute MI after reperfusion with thrombolytics or PCI. I think that's often the scenario that you've probably encountered more likely in a test question than in person, but some of you may have seen it. But it can also be seen post-resuscitation from cardiac arrest and after use of digitalis, a volatile anesthetic, or in cocaine, or those with potassium abnormalities. And then sometimes in those that have an underlying cardiomyopathy as well. Usually this arrhythmia is benign and it's well tolerated, and it'll resolve once the sinus rate exceeds the ventricular rate. Usually antiarrhythmics should be avoided because they can occasionally cause hemodynamic deterioration in patients that have AIVR. In rare cases, when you do have a patient that's symptomatic, maybe from low cardiac output, then you can use atropine to increase the sinus rate, and to the point that it exceeds the ventricular rate, and then it should resolve. Next, we're going to discuss Torsades de Pointes. This is a particular type of polymorphic VT that's characterized by QRS complexes that have changing amplitude. Here, the rate is usually 200 to 250 beats per minute. And there's prolonged ventricular repolarization with QT that's longer than 500 milliseconds. It can be caused by hypokalemia, meds that prolong the QT interval, or congenital abnormalities that lengthen the QT segment or cause bradycardia. There's management to initially break the torsades, and then there's management to prevent it from recurring once you've seen it. So when you initially need to break it, go ahead in the room, make sure you attach defibrillator pads and don't leave the room when you have patients that are like this because they can rapidly deteriorate. Give them magnesium sulfate IV. It should be 2 grams over 10 minutes. And if they still haven't broken, you can repeat it again if there's no response. If they do become unstable, then you can perform unsynchronized defibrillation. It's usually unsynchronized because you're not going to be able to get the AED to recognize a QRS complex because it's so erratic. Then once you've broken it, to prevent recurrence, you can give magnesium 4 grams IV over an hour, and then you can give 1 gram per hour. At this point, you can target a level of 3.5 to 5. You don't need to worry about checking magnesium initially. You just give it initially to try to break the rhythm. And then later on, if you're trying to prevent recurrence, then you can kind of try to target a level. You should also treat hypokalemia to a target of greater than 4.5. You can do temporary atrial or ventricular pacing, which we'd kind of mentioned before as a treatment for VT as well. You can give isoproterenol infusion and target around 110 beats per minute so that in this case, what you're doing is you're preventing bradycardia, which is a setup for it. So you're trying to increase the heart rate here. You can also give lidocaine 1.5 milligrams per kilogram load, followed by 1 milligram per minute. And you should stop any offending agents that are prolonging the QT interval. Finally, we're going to discuss ventricular fibrillation and Flutter. These are 2 separate entities, but they're really treated the same way, and it's only really hypothetical that you even have a difference. Both of these are fast, erratic rhythms that are characterized by hemodynamic collapse. With ventricular flutter, you can usually see waves that are theoretically going 300 plus beats per minute, but usually it's so fast that it could be difficult to tell. You get continuous rapid discharges from numerous automaticity foci when you have ventricular fibrillation. And this is usually in response to profound hypoxia. The irritable foci suffer from entrance block, so they can't be overdrive suppressed, and they all fire at once because of that. And then with ventricular fibrillation, the rate is hypothetically 350 to 450 beats per minute. And it's hypothetically just because it's so fast that sometimes it's difficult to tell. And this ECG is showing, as you can see, this erratic, fast, wide complex. The features, so this might be seen in patients that have coronary artery disease with antiarrhythmic drug administration, after an electrical shock during cardioversion, or during attempted competitive ventricular pacing for VT, which we mentioned earlier. Patients will have a loss of consciousness and apnea. They'll likely have absent heart sounds. You won't be able to obtain blood pressure. And if you don't act quickly, they're going to suffer from sudden cardiac death. The management, this is straight from the American Heart Association and the adult cardiac arrest algorithm. So this is just a little reminder in case it's been a while since you've had to run a code. So if you have a patient that goes into VFib or Flutter, you need to start CPR. pretty much if you see that you're dealing with VFib as the rhythm, you want to try to shock the patient as soon as you possibly can. So start off with defibrillation. You perform CPR for 2 minutes before doing a rhythm check and shocking them again if it's VFib or Flutter. And then you should be administering epinephrine every 3 to 5 minutes. So the dose is epinephrine 1 milligram. After that, you can consider giving amiodarone or lidocaine. The first dose of amiodarone is 300 milligrams, and then any subsequent doses of amiodarone are 150 milligrams. For lidocaine, you give 1 to 1.5 milligrams per kilogram initially, and then any subsequent doses should be 0.5 to 0.75 milligrams per kilogram. Again, these medications should be administered every 3 to 5 minutes while you're still trying to get ROSC. The voltage for defibrillation, most of the time you'll have biphasic defibrillation, and it'll be 120 to 200 joules. If it's monophasic, it's 360. With biphasic, you can just go ahead and give 200 joule shock if you want, or if you start at 120 and it's not successful, you should do 200 joules on the next try. Now that we've covered the common types of ventricular arrhythmias, I didn't go into particular types of VT. I think that's best learned over the course of fellowship, and you can, go over the particular treatments and situations for each type. But for now, let's stick to those basics and we'll go into some practice cases. So here's case number 1. Mr. JD is a 72-year-old man that has a history of hypertension, dyslipidemia, CAD status post PCI to the mid-LAD and left circumflex 3 years prior, with resultant HFrEF with an EF of 35%. And he comes to the ED with palpitations and weakness for the past 2 hours. The ED calls you and they see this ECG. Okay. And the question is, what is the rhythm? Is it VT or is it SVT with the Barency? And I'll go back. Okay. The answer is VT. Going back to the ECG, the point I made about looking at AVR, if it's positive, that means you're up in that northwest axis, and that's usually only seen with VT. Also, this ECG is showing that the RS complexes from the start of the R to the bottom of the S is greater than 100 milliseconds. And that was what I mentioned with ventricular tachycardia. The depolarization is happening cell to cell initially in the ventricular myocardium. And so it moves slower and there's slow initial depolarization, which is seen in this ECG. So it's most consistent with VT. Here's our next case. Miss PL is a 68-year-old lady with a history significant for type 2 diabetes and active tobacco use. She came into the ED with shortness of breath and jaw pain and was found to have a STEMI with 2 millimeters ST elevation and leads 1 in AVL. She was taken to the cath lab and underwent PCI with 2 drug-loading stents at the first diag. She felt well and went to the ICU for ongoing monitoring. 2 hours later, the nurse calls to tell you the patient's telemetry just changed morphology. On arrival to the room, the patient sitting upright and talking and is asymptomatic. Her blood pressure is 111/71. She has no JVD, no appreciable murmurs. Her lungs are clear and she has no peripheral edema. Her right radial access site looks well and shows no hematoma. And here's her EKG. The question here is, in addition to ongoing monitoring, what should you do next? we'll go back for just a moment to look at the ECG again. Okay. So do you want to give a bolus of 150 milligrams of amiodarone and start a drip? Do you want to call the interventional attending to discuss taking the patient back to the lab? Do you want to check electrolytes? Or do you want to give lidocaine 1 milligram per kilogram IV push? The answer here is to check electrolytes. Okay, so this is if you've had a minute to make the appropriate diagnosis. This is AIVD, and the rate is just under 100. And even though you might think that you're supposed to do nothing, and it's tricky, and you think check electrolytes might be the answer to torsades, if you remember, sometimes potassium abnormalities can also cause this rhythm. So even though the scenario here is kind of showing, this is a patient that was just reperfused, and it may just be due to that. It's also a good idea to check electrolytes because potassium abnormalities can also cause it. Okay, case number 3. This is an 81-year-old lady with an unknown history who's brought into the ED after collapsing while walking off a bus. On arrival, EMS initially noted a weak pulse, but while in transit, she went into pulseless VT. She's had high-quality chest compressions for the duration of the code. She received 1 dose of epinephrine, and she's been defibrillated twice. She remains in pulseless VT, and she's brought into the ED. Which of the following medications is reasonable to consider next? So she's already had epinephrine, and now we're going to figure out what we might want to give next. There's multiple options that you have, but here the only 2 options are lidocaine or amiodarone. So are you going to give lidocaine 0.5 milligrams per kilogram, lidocaine 1.5 milligrams per minute, amiodarone 150 milligrams, or amiodarone 300 milligrams? The answer here is amiodarone 300 milligrams. The lidocaine dose is incorrect. And amiodarone, you would give 150 milligrams only after you've given a 300 milligram dose first. So amiodarone 300 milligrams is the correct answer here. And our last case is a 63-year-old gentleman that has a history of hypertension, CKD3, depression, and prostatitis, who came into the ED with weakness, nausea, and vomiting after eating at an outdoor food vendor. He's been evaluated with suspicion for gastroenteritis. His home meds include amitriptyline, Norvasc, Lasix, and Bactrim, which he was just prescribed 3 days prior for his prostatitis. Here's his EKG. Okay. So all of the following are reasonable treatment options, except which? A, discontinue all meds that could cause QT prolongation. B, replete potassium to a goal around 4.5 milliequivalents per liter. C, check serum magnesium level and replete if less than 5 milligrams per deciliter. Or D, prepare for possible defibrillation. Okay, the answer here is check serum magnesium level and replete if less than 5. So here, what you're doing is identifying that the rhythm is torsades. All of these are good treatment options. You should discontinue any medications that could be causing QT prolongation, and he had several. The potassium, you can try to replete to a certain goal, but with magnesium level, you shouldn't be checking the level and repleting only if it's less than 5. When a patient has torsades, you should be giving them magnesium regardless of the level initially to try to break it and keep them out of it. So you don't need to check the level. That'll just lead to a delay. And you should definitely prepare for possible defibrillation. So those are all of the cases I have to discuss. Please let me know if you have any questions. And thank you again for your attention.